So, sir, 3, 2, 1.
Yeah.
Sir, we are live. We can start the session. Over to you, sir.
Yeah. So a very good evening to all the respected doctors across India. Thank you so much for tuning in live with us. So today is a very important day. We would like to request Dr. N. Arun, eminent gastroenterologist from Chennai, sir. So thank you so much, sir, for your valuable presence today. So before we go ahead, it's a privilege for us to introduce sir. So Dr. N. Arun is an assistant professor of gastroenterology, Department of Digestive Health and Diseases, Chennai. Sir also acts as a visiting consultant gastroenterologist at Bilroth Hospitals, Chennai. Sir is the director of Chandra Gastro Liver Clinic and Endoscopic Center, Chennai. Sir's area of interest is post-liver transplant, immunosuppressive guidelines, and plasmapheresis in ACLF. Apart from that, sir is a member of prestigious organizations like the ISG, INASL, SGI, and IAP. So it is a privilege for us, sir, to have you here today. And sir, with this, I'll request you to take over, sir, and guide our doctor, sir, regarding today's topic, sir. Thank you so much.
So good evening, one and all. Just a minute, I will just share my screen and I'll be taking over the session. Whether my slides are visible, sir?
Yes, sir. Please continue.
Yes, sir. So visible. Yeah.
Good evening, respected professors, senior consultants, and my dear friends. It's really a great pleasure for me to be along with you all in this wonderful evening, in this Valentine's Day evening, and taking over much of time, even rather than spending with your Valentine to spend during this academic event. It's really a great honor for me to be along with you all. And once again, I would like to thank Lupin Pharma for being here to organize this pan-India discussion about the role of antioxidants in liver injury. It's a simple topic for discussion, but nowadays this is more emerging and most of the medications are being coming in the field of gastroenterology to discuss about this area. So what is the role of antioxidants in liver injury? So if you want to discuss about that, my area of interest to disclose to you all should know about the role of antioxidants first. What do you mean by the free radical? How the free radical is going to involve and what are the components of free radical is going to be there, and followed by how the antioxidants is going to take over. If at all, if there is any reactive oxygen species is going to set in, how the process is going to be involved. Apart from that, what are all the various liver injuries you are going to expect in, what are all the various liver conditions, what are the various liver pathology, this antioxidants is having a role. And these are all the more interesting and new upcoming area that is happening in the field of hepatology to take over right now with you all. So if you want to discuss about this, see, if you want to look that liver is one of the fantastic and wonderful organs, one of the most versatile organ. And in India, the most common cause, the major GI pathology is almost going up to liver, is one of the most common cause of illness throughout the world. And if you're going to look into your liver disease, if the patient is going to present to you with evidence of chronic liver disease, which means the patient is going to land up with evidence of liver cirrhosis or other complications like jaundice, or the patient may develop coagulopathy, or the patient may develop hepatic failure, or the patient may develop hepatic encap, like this kind of presentation. This kind of presentation, if it is going to last for more than a period of 6 months, it's nothing but chronic liver disease, and whether it is compensated or decompensated based upon your clinical presentation, we need to take on. And apart from that, see, this is one of the most common cause of morbidity and liver pathology, various etiology. It could be because of alcoholic, it could be because of non-alcoholic, the source may not be identified, it could be because of metabolic, pediatric, right from pediatric to adult. There are various events to look over this wonderful organ which has been there. Almost alcohol, even then it is being ranked very high in India, and in India is going to become the world alcohol capital by almost around 2025. That is being strongly established, and most of the time, unless and otherwise, if you're going to cut down this event, the alcoholic liver disease and other pathology definitely is not going to come down. So before we are entering into the session, we should know what do you mean with the basic biochemistry as well as your basic physiology about these free radicals. If you want to discuss about these free radicals, it means it are atoms or molecules in which there will be unpaired electrons will be highly unstable and they are usually reactive. These are all more theoretical. If you want to discuss, these free radicals will predispose to a formation of reactive oxygen species. These free radicals will be highly unstable. So the presence of unpaired electron, will be predisposing to multiple illness. So normally during your physiological condition, this has to be there. But once the limit, once the toxicity, once the limit is going to exceed your normal range. So there, once the pathology is going to set in, the free radical mediated damage is going to stimulate. So the free radical scavengers is the most important thing to take over on this pathology. So what is the role of free radicals? So if you want to discuss about that, so it will be either because of oxygen-based free radicals or nitrogen-based free radicals. So we all know that what are the various oxygen, it could be because of superoxide, it could be because of hydrogen peroxide, hydroxyonion. So all these things can be categorized as oxygen-based. Or if it is because of nitrogen-based, it could be because of peroxynitride or nitrogen NO2, or all these things can be based upon the nitrogen-based radicals. These are the two basic biological system in which it's being categorized. So what is going to happen once a chemical characteristic is going to set in this process of free radical mediated damage? So they will be going for the most of the liver pathology. As you all know that the liver is a major source of ATP production, metabolism, the major source of most of the drug detoxification and various metabolic enzyme pathway is going to act over in the liver. Once this kind of chemical characteristics, the reactive oxygen species or reactive nitrogen species, if it is going to form, that will predispose to lipid peroxidation, will predispose to DNA strand breaks and predispose to multiple organ injury. That will predispose and that will make the patient to land up in multiple complications. The patient can develop fibrosis, cirrhosis, and other complications like even hepatocellular carcinoma, one dreadful complications in liver pathology to set in. So the basic thing what you're supposed to know about, it could be because of nitric oxide. These are the various signaling pathways which is being involved in the role of free radicals, more of theoretical one. It could be because of nitric oxide pathway. It could be because of superoxide. All these things has to be there in a reasonable amount to overcome in a normal physiological process. And once this normal physiology is going to take over, this abnormal free radical metabolism is going to cause a more perturbant injury which is going to set in. And if you want, what are the various sources? It could be because of endogenous sources, or it could be because of your exogenous sources. What are the various endogenous sources? The normal liver mitochondrial function, the ATP production is a major source of that. If you're going to see the liver, the various cells are there. It could be because of ito cells, it could be because of stellate cells, or it could be because of Kupffer cells or endothelial cells. The various cellular pathway is there in the liver. And if various cells are there, in these cells, if any perturbating injury, if it is going to happen, that will predispose to all this organ damage, like organelles damage, like mitochondria, peroxisomes, endoplasmic reticulum, all the neutrophil, eosinophils, all these things going to accumulate will predispose to liver injury, and followed by the macrophage activation, other process going to set in. And once the exogenous, what are the various exogenous factors to involve in this free radical mediated injury is nothing but you are smoking. Suppose if you are a smoker, if you are alcoholic, if you are having any perturbating infections, like suppose if you're having any chronic hepatitis B or C, or if you're having ischemic reperfusion, or if you are being exposed to too much of ultraviolet radiation or photooxidation, and these are all the various chemicals. Suppose if you are going to expose yourself to multiple drugs, for example, if you're going to expose yourself to paracetamol poisoning or something, you may land up in drug-induced liver injury or multiple chemotherapeutic agents. These are all the various various exogenous factors is going to involve in the pathogenesis or genesis of reactive oxygen species to predispose to free radical mediated injury. So the generation is not, the generation of reactive oxygen species is a natural part of aerobic life. So this will predispose to signal transduction pathways is going to be activated, and against various invading microorganism and gene expression to the promotion of growth and growth or death. So once, oxidative stress is going to form, the nitrogen species is going to be activated, the reactive oxygen species is going to be activated, which will predispose to reduction of antioxidants. So these antioxidants, the naturally occurring antioxidants, or once you are going to supplement the patient with the external source of antioxidant, so there will be a reduction of antioxidants, which will worsen this scenario to predispose to various other pathology which is going to happen in our liver. So as we all know that the liver is one of the major target by reactive oxygen species, which will predispose to macrophage activation, mitochondrial dominance, and peroxisomal activation. That what I mean discuss. Once this pathway is going to get activated, what is going to happen? It's very common. Once this everything is going to set in, the common pathology will be a cytokine storm will be there. The tumor necrosis factor is going to be activated. Kupffer cells, oxidation, oxidative stress, all the cells is going to be get activated, which will predispose to inflammatory damage, which will be predisposing to apoptotic mediated damage. These are all the basic pathophysiology, how this reactive oxygen species, how this free radical is going to damage. So the hepatic stellate cells, which is one of the main, which is going to triggered by the lipid peroxidation, which is predominantly caused by your oxidative stress. These are all the things which is going to be involved in the pathway of your reactive oxygen species involvement. So it could be because there are various triggers for that. Like what I've been discussed, it could be because of in various, even this kind of things will be happening, even in acute viral hepatitis, sometimes in chronic viral hepatitis, sometimes in alcoholic liver disease, sometimes in non-alcoholic steatohepatitis, sometimes in drug-induced liver injury. Moreover, these are all the various things which is predisposing to. And there are these things, oxidative stress, what is going to happen once the damage is going to set in, even to the extrahepatic organs. It can involve your liver, it can it can involve your kidney, it can involve your other organ systems, cardiovascular, respiratory, all other organ systems can be involved. It can go from multi-organ dysfunction, other pathology to setting. So we all should know what is this redox homeostasis, which means the reduction oxidation has to happen in a proportion, in equal proportion, in a normal propensity to take over this pathology. So what is this redox mechanism? The ROS generation, that is reactive oxygen species, which is going to generate, and ROS elimination. So how the reactive oxygen species is going to get eliminated. So if you want to look for the reactive oxygen species generation, mainly by the electron transport chain pathway, cytochrome damage, cytochrome P450 activation, lipooxygenase pathway, NADPH pathway. These are all the various methodology, various process in which your ROS is going to generate, followed by how the ROS is going to eliminate, mainly by always you should remember that glutathione is one of the strong potential antioxidant. Like if you're going to think about the glutathione GSH, which is in the reduced form of glutathione, that has to be there to enhance this ROS elimination. Apart from the glutathione peroxidase, which is going to involve in the processing of maintaining glutathione in a reduced state, and superoxide dismutase, catalase on all the various vitamins which is being involving, like vitamin C, E. As we all know, vitamin E as being having a strong potential role in the management of non-alcoholic fatty liver disease, and also vitamin E nowadays there are more conceptual involvement being happening even for alcoholic liver disease. Some potential papers are coming up. So as I had discussed with you, what are the various risk factors to cause this oxidative stress? So as we all know that it could be because of your excess weight. If your BMI, if it is going to be more than 25 to 30, and if you're going to be your diets, which contains high level of carbohydrates and fats and sugars, which contain more of processing of more processed food, and you're being exposed to multiple radiations, and you're being exposed to chronic alcoholic smoking, another habitual involvement. Apart from that, your pesticides, your drugs, various chemicals and other things which are all predisposed to this. See, this is how the pathway of oxidative stress is going to happen. If you are going to look these exogenous and endogenous factors, this is being taken from a recent paper. So if this exogenous pathway is going to involve like your alcohol and drugs, and endogenous inherently, if you are going to be obese, if you are going to have insulin resistance, all these things, what is going to happen? That will activate your ROS, you activate your reactive oxygen species developing, and will predispose to oxidative stress. Once this oxidative stress is going to happen, what is going to develop? The mitochondrial dysfunction is going to set, followed by the patient may land up with inflammation, and the patient can go for chronic hepatitis and other things. So also it will be acting on your DNA damage, lipid peroxidation, and protein adduct formation will predispose to steatosis. You all should remember the common formation for fatty liver. The steatosis is one of the most common, even for fatty liver, also for alcoholic liver. The steatosis process is going to set in, followed by the patient can land up in hepatocellular carcinoma. So the hepatic stellate cells has to be activated in a proper manner. Once this hepatic stellate cells activation is going to get worsened, more of hepatic stellate cells activation, this will predispose to fibrotic changes. This will finally, the fibrosis can land up in a shrunk up state of liver, which is nothing but cirrhosis, will predispose to all these complications, mainly because of your reactive oxygen species mainly predisposing to oxidative stress, formation of mitochondrial dysfunction. So this is the outlook of what I've been saying about that. So mainly the antioxidant defense mechanism has to be there to enhance all these reactive oxygen species to control in a proper way, like catalase, superoxide dismutase, and glutathione peroxidase. All these things has to be maintained in a proper manner to overcome this reactive oxygen species involvement to cause various liver damages. So outlook of what are the various antioxidants, as we all know, it's been naturally derived or been externally supplied by your foods or something else, or inherently acquired, like enzymatic antioxidants like SOD, that what I've been discussed with you, or it could be because of non-enzymatic antioxidants or nutrient antioxidants, and so much of metabolic antioxidants, like for example, coenzyme Q10, glutathione, L-arginine, uric acid, so many others, and nutrient antioxidants like the diet, which you suppose if you're going to consume, that I'll be coming in my upcoming slides. I suppose these are the based upon your diet, what are the various antioxidants you're going to obtain. So the main antioxidant, the master of all the antioxidant that we are going to discuss, the more papers are being involving and the more gastroenterologists be using this kind of molecule in the management of various liver pathology, is nothing but glutathione. So the glutathione, it will be always, you should always, it's a ubiquitous and tripeptide, which will be forming along with L-glutamine, cysteine, and glycine. So it is one of the master antioxidant, and it's involving the major antioxidant defensive process. So this glutathione will be, the formation will be in GS, it will be in a reduced glutathione form. We need to prevent that glutathione should get oxidized to form glutathione disulfide. So GSSG is a glutathione oxidized form. In order to prevent that and make the glutathione to stay in a reduced state, that is our motive for most of the time if you're planning to manage a patient with liver injury. So glutathione depletion will contribute to multiple complications, will lower your immune system, and nowadays even glutathione being used in the COVID scenario and other scenarios. There are multiple indications for glutathione, but our interest to talk more in hepatic pathology, and thus will predispose to increase vulnerability for the further infections to the liver, will reduce, and which will be reduce ability for you to detoxify the various other drugs and other processes to be managed. So this is outline of the structure of glutathione. And if you're going to discuss about this glutathione process, that's discussed, like glutathione will be in the reduced, and that has to be maintained properly. Once there is a loss of electrons, so oxidation process is going to take over. This GSSG oxidase form, that means glutathione disulfide form, is going to be there. And if the glutathione disulfide formation is going to be there for a longer duration, that will predispose to multiple complications for liver injury to take over. And so more than 90% in physiological forms of cellular glutathione pool, as we have discussed right now, it will be in the reduced state, and less than 10% of the forms will be in the oxidase state. So our intention to make this glutathione in the reduced phase. So this is how the glutathione biosynthesis, nothing much more of theoretical part. So you should remember the basic things, because all the major pathways of folate, homocysteine pathways is going to involve this glutathione synthesis, followed by from homocysteine to cysteine, from cysteine to glutathione. This is a major thing. And this cysteine, sometimes beta and intermediate process, all these things can be used as an antioxidant. And here our intention to make this glutathione reduce rather than going for the oxidase phase, if you want to use this in a proper manner. And apart from that, the normal human concentration of glutathione will be around 0.1 to 10 millimolars. It will be predominantly very high in the liver, but it can also located in the spleen, kidney, lens, RBC. Also, it can be in the leukocytes also. So the plasma concentration should be in the micromolar range, less approximately around 4.5 micrometers. So our micromole. So our intention will be the various exogenous factors or various endogenous factors to cause damage and to induce this reactive oxygen species formation and to deplete this reduced glutathione levels. So in order to avoid that, we need to have a strong antioxidant support to make this glutathione the reduced state. So if you want to look into this, is one of the most the brief what are the extra other things which we are looking into the glutathione is the regenerative ability. It's not only for itself but also for other antioxidants like vitamin A, C, and E. It's one of the most concentrated intracellular antioxidant, and It is the only non-enzyme antioxidant that does not itself become a free radical after it has been neutralized to be after it has neutralized a free radical. So these are all the various physiological roles of your glutathione. So it can predispose to cell growth differentiation, metabolic reaction formations, leukotriene synthesis, free radical scavenging, and detoxification of xenobiotics, which is one of the main things which is happening in your liver and will be involving in translocations. So all these things will be there if your physiological roles of glutathione. So our interesting area, what is going to happen if the patient is going to be a chronic alcoholic? So the main thing, the main area of interesting discussion starts from right now. So once the patient is going to be a chronic alcoholic, so you all should remember India almost leads by 2020-25. India is going to lead worldwide by alcoholic. This is going to top over. India is going to make a clear lead in alcohol. So by 2025. So what is going to happen? So alcohol will predispose to multi-organ injury, mainly by hepatic injury. So if you're going to look right now, almost around 2.5 million global world population, which is being occupied by alcoholic liver disease. And if you're looking into your GA pathology, among that, around 30% of the mainly because of the alcoholic liver and alcoholic induced pancreatitis. So all the GA pathology mainly which is going to happen in your because of alcohol will be mainly because of alcoholic liver disease and apart from alcoholic pancreatitis. So what is going to do? So alcohol can perturbate multi-organ system, can predispose to your alcoholic liver disease. How the alcoholic liver disease is going to form? So if you're going to consume alcohol, see, the men are more commonly dangerous factor. Also the women can be more exposed. So if the man is going to take the alcohol at around 60 grams per day, or around 60 to 80 grams, sometimes a toxic dose of alcohol, that's what they were mentioning. Or once a patient, even for female, if the patient is going to take more than 20 grams per day, the female are more vulnerable to alcohol-induced damage because of estrogen and other pathway metabolism, or because of COP activation. All these things, because female gender are more vulnerable for alcohol-induced damage. So how this alcohol is going to induce your damage, that's the area of interest to discuss. So that is also predisposing to reactive oxygen species formation and reactive nitrogen species formation, your formation of lipid peroxidase, and will be predisposing to necrosis, apoptosis, and hepatic stellate cell activation and fibrogenesis is going to set in. So as I discussed with you, the main modality will be oxidative mitochondrial damage, which is going to happen. It will be made mainly by a pro-apoptotic fragment, which is going to be activated, nothing but a tumor necrosis factor, which is going to be involved in that. So our intention, so if you're going to look into this pathogenesis of alcohol-induced liver injury, see, this is a various which has been taken from the recent paper. So if you're going to take alcohol at a lower dose, cytochrome P450 only is going to be activated. But once the alcohol intake, if you're going to take at a higher rate, suppose if you're going to take plenty of more than 120 grams, and if you're going to consume alcohol for a longer duration of time, so your MEOS is going to be activated. What is this MEOS? Nothing but microsomal ethanol oxidase system. So yes, MEOS induction will predispose to further damage. See, the alcohol metabolism can happen only by, as you all know, right from a basic chemistry, alcohol to aldehyd, aldehyd to acid. The alcohol will be metabolizing to ethanol. So for example, if you're going to consume, will be metabolizing to acetaldehyde formation. This acetaldehyde will predispose to addict formation, will be free, will cause your mitochondrial electron, and NADPH process is going to be get activated through this aldehyde dehydrogenase pathway. So once this aldehyde dehydrogenase through that NADH activation will cause a mitochondrial electron transport chain to generate, and followed by which will predisposing to excess NADH can lead to your fatty liver, your hyperlipidemia, your uncontrolled, your hypoglycemia, your hyperlactic acidemia, your hyperuricemia, and gouty. So many other complications are there to take over. And if you're in case if you are going to have your oxygen deficit, will predispose to multi-organ damage, will be having a lipid disturbances in lipid metabolism, your fatty acid metabolism, and your oxidation, your beta oxidation pathway, the fatty acid binding protein going to be activated. All the antioxidants is going to be depleted. The antioxidant glutathione will going to come down, and your lipid peroxidation is going to set in, which will further worsen this scenario. So once the deactivation of proteins and other pathways, if it is going to be activated, the repair of DNA damage will be inhibited, which will further accelerate. Suppose if you are going to consume drugs, there will be accelerated metabolism, which will enhance the degradation of testosterone and retinoids based energy wastage, all these things. So the alcohol will make your damage mainly by the enzyme pathway of CYP450, and also by microsomal ethanol oxidase system will perturbate your liver damage to set in. So once this, how the mechanism is going to happen. So as I discussed, the liver is being taken over by multiple cells. The Kupffer cell is going to get activated. The hepatocyte pathway once gets damaged by this continuous use of alcohol, this will predispose to apoptotic activation. The apoptotic bodies is going to form, will predispose to Kupffer cell activation, will predispose to all the natural killer cells. Will then, since the activated Kupffer cells will also release the tumor necrosis factor, the trial factor activation will predispose to chronic apoptosis. And this kind of, if it is going to happen for a longer duration, that is the main problem for you to land up in hepatocellular cancer. So this inflammatory process, initial phase will be fibrosis and cirrhosis, followed by around 4 to 5% of the population can land up in hepatocellular carcinoma. So if you are going to look into the semiology of alcoholic liver disease, the most common presentation will be steatosis. Around 95 to 100% of the population will land up in steatosis over a period of time if the patient is going to consume alcohol. Around 30 to 40% of the patient in steatosis group can go for non-alcoholic steatohepatitis, with one of the worsening of condition, followed by your enzyme elevation, followed by some histological changes like your ballooning and degeneration is going to set in. So this NASH, once you cut down the alcohol, can predispose, can revert back again, or else once the patient, even after this, the patient is going to continue the alcohol intake, can land up in fibrosis, and then to go for cirrhosis, and finally around 1 to 4% of the population may go for hepatocellular cancer. So in this condition, the glutathione is definitely having a strong potential role in order to maintain your cellular homeostasis. That is how, and also it is going to suppress your pro-inflammatory cytokines and leukotrienes and other pathways to get activated. So even for alcoholic liver, alcoholic hepatitis, and cirrhotic condition, we can use glutathione. So glutathione is available in various formulations, could be IV or oral, but depends upon your clinical severity. We need to choose the formulation. We can go at a rate of around 2,000 to 600 to 2,400 milligrams twice daily by slow IM or IV route, and sometimes even oral route is also there. So these are all the various papers quoting the efficacy of glutathione. So if you're going to use, right from 1993, there are papers to quote that, and recent paper by 2017, what I've been mentioning about the alcoholic hepatitis, they've been studying the efficacy of glutathione, and definitely the enzyme levels, the ALT, GGT, all these things can be having a reasonable depletion. Can be having a reasonable improvement if you're going to supplement the glutathione for a reasonable duration of time. And how this glutathione is going to act in your acetaminophen-induced hepatotoxicity. As you all know that the King's College criteria has been mainly based upon your paracetamol poisoning as well as by non-paracetamol induced involvement. And this acetaminophen-based toxicity, what they're going to do that if the high possibility for this patient can land up in acute liver failure if the patient is going to consume a toxic dose of paracetamol. Even in pediatric age group, this is going to happen because of most of the time, even the formulation which is being available in syrup or drops, there is high possibility for this kind of patients can land up in paracetamol toxicity. And as we all know, the safest antidote for this paracetamol toxicity is N-acetylcysteine. Also, methionine is being used for paracetamol toxicity, which is being recently available in the market. And acetaminophen-induced hepatotoxicity, how this is going to set in mainly by your CYP2E1 pathway and the toxic metabolite which is going to get accumulated, and your reduced glutathione which is going to get depleted. So our intention, once you start this preparation on N-acetylcysteine or other support, so what is the motive? So we need to replenish the glutathione stores. Once the glutathione stores is going to get replenished, the paracetamol toxicity will going to be involved. And there are all various coexisting comorbidities like thyroid, if the patient is having low weight, if the patient is having other complications. These are all the other scenarios, apart from the area of discussion, can worsen your acetaminophen-induced toxicity, and mainly by the formation of intermediate metabolite is nothing but NAPQ. It's N-acetyl parabenzophenamide. So if these things is going to be there, the acetaminophen toxicity will predispose to acute liver failure, and to almost reduce that. So we need to replenish the glutathione. There is a potential role for glutathione in this condition also. And for example, if you're going to take in this viral hepatitis C, what is going to happen in viral hepatitis C? So that is it's going to form a structural protein. So if the one in this condition also, once the patient is going to a chronic hepatitis, as we all know that hepatitis C, there is high possibility for the patient to go for chronicity most of the time, and this patient can go for hepatocellular cancer. So this kind of patients, various metabolic, various inflammatory processes like TNF activation, FASL activation, and exogenous reactive oxygen species activation will perturbate your redox reactions, will predispose to your various injuries in your cellular compartments like your cytosol and mitochondria. So viral hepatitis C can also predispose to liver injury, and there is a potential role for glutathione in this condition also. As you all know, very upcoming scenario, not only in the Western countries, also in our Indian scenario, the NAFLD is being strongly predisposing right now. Almost around 9 to 32% of the population is being involved, even in India too, because our metabolic liver disease pathology is being there, and metabolic now NAFLD, the terminology is not much in use now. MAFLD, metabolic associated fatty liver disease, has been taken over. But even then, this NAFLD is one of the common presentation right now, which we are seeing routinely in our daily practice because of uncontrolled diabetes. If the patient is long-standing hypothyroid, once the patient is going to a type, predisposing obesity, or even now new terminology like lean NASH, which is being involved in that. So all these things will predispose to non-alcoholic fatty liver disease. Even if you're going to consume alcohol at a minimal rate, around less than 20 grams per day, that is high possibility for you to land up in non-alcoholic fatty liver disease if you're coexisting, if you're going to develop this metabolic syndrome and other complications. So uncontrolled, sedentary lifestyle, uncontrolled dieting, obesity, type 2 diabetes, and other things, which is predisposed to around 25% of the adult population is going to have NAFLD. And this NAFLD, among this NAFLD patient, there is high possibility around 10 to 20% can go for NASH. And in this NAFLD patient, around 7 to 19% can go for fibrosis, and later around 1 to 4% of the population, around 5 to 10, and 1 to 4% of the population can go for around cirrhosis, and then for liver cancer. So this is how the spectrum of NAFLD is going to involve. So what is the main thing here? The palatin-like peptide, other things which is going to be involved in the genetic polymorphism. And apart from that, you are uncontrolled, your fatty liver, your NASH and cirrhosis, and followed by what is going to happen? Your increased circulating free fatty acids. So your free fatty acids will be predisposing to various oxidative stress, which will contributed by your insulin resistance. Once the insulin resistance is going to happen, the patient is going to be in increased gluconeogenesis, which will predispose to type 2 diabetes. These things and all will be going to set in. Along with that, your genetic and environmental factors also is going to be involved in that, followed by the increased free fatty acids will predispose to oxidative stress by lipid peroxidation, protein oxidation, reduced level of antioxidants, all these things. So in this, there will be impaired glutathione turnover. That's a primary hit by the oxidative stress. Even in this condition, glutathione definitely can be having a role in the management of oxidative stress in non-alcoholic fatty liver disease, by a paper which is quoted from 2013 by Cesar et al. Group. The oxidative stress can be having a critical factor in non-alcoholic fatty liver disease pathogenesis can be considered. So this is from BMC Journal of Gastro. So in this, the efficacy of glutathione in NAFLD, in which they have done an open-label single-arm multi-center pilot study, in which they have shown that they have been underwent this glutathione for the first 4 months of life at a dose of around 300 milligrams, followed by they have a reduction of cap measurement. That's in the control identified by a fibroscan. If you're going to measure your cap and liver stiffness, is going to be definitely come down if you're going to subject the patient in NAFLD and in the harm of glutathione. So the newer molecule, which is more of biological event, which is like astaxanthin, now even can be considered as an antioxidant, though it's a carotenoid form which is predominantly found in aquatic animals like salmon, trout, and lobster and shrimp, which is going to be there. This astaxanthin can be considered a strong antioxidant, which is being predominantly found in nature. It is called as the king of carotenoids, and it's more of a long chain compound. So this antioxidant of this beneficial effect of astaxanthin will be having a multiple beneficial role, like it can have a neuroprotective, skin regenerating, and mainly for your non-alcoholic fatty liver disease. There is strong potential for this astaxanthin can be considered along with glutathione in the management of NASH and other process. And also it will be involved in cardiovascular, your capillary blood flow, and fatigability of your eyes and vision, and all these things. There is a potential role to prove this astaxanthin also been involved. So it can act as an antioxidant, and next to that, it can also act as an anti-inflammatory, and mainly in non-alcoholic fatty liver disease, in the pathway of insulin resistance, in the pathway of free fatty acid accumulation, which will be involving in lipogenesis and triglyceride accumulation, which will overcome by the beta oxidation fatty acids. All these things will be strongly controlled by if you're going to use astaxanthin over a duration of time, and it will prevent the lipotoxicity. It will prevent the pro-inflammatory cytokine activation, or it will reduce the effect of inflammation if you're going to subject the patient with astaxanthin for a longer duration of time. So this is how we've been recently taken from a paper from Lee et al. In 2015. What I mean, if you're going to consume fat, along with high fatty diet and no astaxanthin, there is high possibility for you to go for a excess fatty accumulation. And if you're going to go for a high fat diet with astaxanthin support, your fat accumulation definitely is going to come down. Only it has been proven very well in these slides. So it's also going to improve your liver fibrosis. If you, the fibrotic pathway, as we all know, the TGF beta, which is going to be taken over. And if you're going to subject this patient with astaxanthin, so there is high possibility for you to come down with liver damage and the fibrosis. Your fibrotic index scoring definitely is going to improve, and your CAP values is going to come down if you're going to subject your with astaxanthin. So there are various benefits, more of theoretical one. So strong antioxidant, it's one of the newest strong antioxidant can be considered, along with, it reduces also your LDL levels and TGL levels, and prevents the fat accumulation, enhances your immune system, and it will ameliorate your liver fibrosis and prevent progression of your you to develop a chronic liver disease and other pathologies. So along with like vitamin C, E, beta carotene, it is one of the super antioxidant, also can be considered in the defense mechanism, which is having around 100 to 500-fold more greater potency than tocopherol and than other carotenoids. There are various papers to show the efficacy, which has been taken recently from Nature Journal. So, really reverses your insulin resistance and steatohepatitis to a reasonable extent if you're going to subject along with astaxanthin. So the recommended dose, we can start by 4 milligrams, or even we can go up to 20 milligrams. We can give in this trial, in this paper, they have been taken up to around 12 milligrams for a period of almost 6 months. And they observe the results of NASH, how it is going to improve when compared to the efficacy of vitamin E in this paper. This is another thing, another antioxidant, what we've been trying is S-adenosyl-methionine. As we all know that the methionine is one of the common pathways which is going to involve in your alcohol-mediated liver damage. So in methionine, what is going to happen? So if you're going, it will predispose to oxidative injury, it will predispose to other formation. And this main pathway is mainly because of S-adenosyl-methionine, which will, in this condition, if you're going to see from methionine to SAM, and will be involved in the formation of homocysteine. So if you're going to look in this graph, it will be because of beta information, also because of dimethylglycine formation, also involving the folic acid reduction like tetrahydrofolate to 5-methoxytetrahydrofolate. All these are the basic biophysiology which is going to be happen mainly by S-adenosyl-methionine can be considered. See, so what is going to happen in alcoholic? The elevated methionine levels and the decreased methionine clearance will predispose to oxidative stress and hepatic stellate cell activation. So we need to subject the patient with S-adenosyl-methionine. So once the patient is going to subject with S-adenosyl-methionine, the changes like hypermethylation, your activation of methionine adenosine transferase, all these things is going to come down, and hepatocellular accumulation and methionine is going to, and significant your level of reduction of S-adenosyl-methionine is also going to be taken over in this once a patient is going to have this kind of liver injury. So like your various sources like viral hepatitis or septic shock, all these things will be having the depletion, will also inactivate your methionine acetyl transferase and other things. So will inactivate this condition if you are having an excellent source of events which is going to perturbate. And in this, and the role of SAM, the various papers is there to quote the efficacy of S-adenosyl-methionine for chronic liver disease. And also you can consider this SAM along with the UDCA in the management of intrahepatic cholestasis of pregnancy, and the usual pregnancy outcome will be good if you're going to use SAM along with the UDCA. So the pruritus, the other serum bilirubin, the enzyme markers, there are some improvement which has been shown in some papers, can be considered even for cholestasis of pregnancy along with UDCA. SAM can be added as a top onto the molecules. And next to that, these are all the various papers being quoted if you're going to use SAM. And the other potential antioxidant like N-acetylcysteine, what is the role of N-acetylcysteine main? So as we all know that N-acetylcysteine, which is going to be the main pathway of one of the major antioxidants, which is going to be targeted in Acetaminophen-induced poisoning. Paracetamol-induced poisoning. So how is it going to act in non-acetaminophen-induced acute liver failure? In our daily scenario nowadays, even now if the patient is going to land up with acute liver failure. So acute liver failure is nothing but if the patient is going to present with severe coagulopathy, if the patient is going to land up with acute onset of hepatic insult, followed by if the patient is going to have hepatic NCAF, if the bilirubin levels is going to get worsened for more than 5, along with if the patient is having INI, if it is going to be worsened for more than 1.5, if the patient is going to land up with acute worsening of symptoms, for this may label as acute hepatic failure. And in this condition, there is a potential role for N-acetylcysteine, can be considered as a strong antioxidant, like what we are going to use if you are going to subject the patient with N-acetylcysteine over a period of time, or a period of 72 hours as the continuous infusion, that having a strong predisposition, a potential factor to be considered as a strong antioxidant, and will be involving your acute liver failure and other process to come down as early as possible. So there are various other things being added on to the armamentarium in the antioxidants like coffee. As we all know that apart from vitamin E, coffee is also been recommended by most of the papers. If you're going to take around 4 to 6 cups of coffee, there is high possibility for you to come down with your liver fibrosis or other things in among the patient with non-alcoholic fatty liver disease. So because it's having also having an anti-necrotic, anti-fibrotic, anti-cholestatic, and chemoprotective and other antioxidative functions. So coffee can be tried if you're going to consume coffee. And along with that, so it prevents cholestasis and necrosis measured by the enzymes gamma glutamine transpeptidase and alkaline phosphatidylate, ALT. All these things have been shown some beneficial effects of coffee if you're going to consume over a period of time. So nothing much to discuss in this. And apart from that, the one which is being derived from milk thistle, it's a natural substance, is nothing but silymarin, but the strong potential beneficial effects of silymarin, even most of the physicians and practitioners are being using, but the beneficial role of silymarin is still a questionable issue when you are going to use that for a longer duration of time. So if you're going to consider this silymarin, how does it going to act? It will be reducing your free radical mediated damage, and also it's going to stabilize your plasma membrane, and also it's going to stimulate your liver cell production, newer liver cell formation. So all these things, and also silymarin is having an effect as an ion chelator in the management of beta thalassemia, who presents to you with evidence of iron overload and other conditions. So silymarin is having some reasonable hepatoprotective properties, but there are not much of papers to quote the beneficial effects of silymarin when you're going to consider in the management of acute injury of liver. So the clinical trials are there to compare if you're going to in a complex to bring down the enzyme levels along with the patient going to land up with acute viral hepatitis, or if the patient is having alcoholic liver disease. There are some papers to quote, but we need more trials to prove this beneficial role, and nothing much about silymarin. So next to that is the consumption of green tea. As we all know that green tea is one of the strong potential antioxidant, anti-inflammatory, and anti-angiogenic. So green tea contains multiple components, as we all know, mainly because of catechin and epicatechin effects. So green tea will be having a strong antioxidant property, and also its being chemical structure will be almost similar to glutamic acid. So green tea can be considered as an antioxidant. So apart from that, the various other antioxidants like betaine, vitamins like A, C, E, your phosphatidylcholine, your BCA, like branch chain amino acids. If you're going to use BCAA for a longer duration of time in the management of hepatic encephalopathy. As you all know, BCAA is valine, leucine, isoleucine, and other things supplemented. Along with selenium can be a metallic properties, can also be considered as an antioxidant. And with that, zinc in the fall, zinc, as we all know, that is being used for multiple conditions. It has been proven beneficial effects for metabolic liver disease in Wilson's and other things. Zinc also can be having an antioxidant property, and definitely it's going to come out with antifibrotic other changes and other naturally occurring antioxidants like your sumac, your clove, clove intake, and acaberry, and sometimes even your extracts from the cocoa plants. All these things can be considered as a naturally occurring antioxidant. See, this is one of the very simple area to be discussed. And if you want to consider the beneficial effect of antioxidants in liver injury, the main thing always you should remember, the reactive oxygen species has to be completely eliminated, and it has to involve in the detoxification process, and the reactive oxygen and reactive nitrogen species formation has to be come down. The glutamate, the strong potency of reduction of glutathione will be there, has to be there. Reduced glutathione formation has to be there in a strong manner. And we'll read once a patient, what is the basic pathology, what is the basic condition you're going to tackle. Suppose if the patient is going to be in hepatic encephalopathy, in this scenario, we can also consider S-adenosyl-methionine and other drugs, along with you can also consider glutathione in the management of acute liver failure, and various other substance molecules like N-acetylcysteine in acute liver failure can be added. And because of drug-induced liver injury, always you should not forget, it could be because of chemotherapy, or it could be because of ATT-induced liver injury, or it could be because of your paroxysmal over-toxicity. So all these things can be having a strong impact by generating your liver reactive oxygen species formation, oxidation reaction, and the imbalance in redox oxidation potential to get involved, all to overcome all these effects. In a nutshell, the antioxidant has to be maintained in a proper way. Along with that, the external source of antioxidants can be considered based upon your clinical presentation, what are you going to tackle. And with this, I would like to rest my presentation, and I'm happy to take up your questions if anything is there to take over, and thanking you all for patient listening.
Thank you so much, sir. That was a very interesting session, especially on an important topic, antioxidant in liver disease. Sir, we have got a couple of questions from our doctors, sir. So shall we take it, sir, one by one?
Sure, sure.
Yeah. So the first question, sir, for the day, which we have received is regarding the your experience and your preferred dose of SAMe, sir, S-adenosyl-L-methionine.
So our experience, see, if the patient is going to be along with alcoholic liver disease, there are some scenarios we have been using as S-adenosyl-methionine along with other antioxidants can be considered. But how long you're going to subject, minimum duration of 6 months. Some patients will be subjecting to around 1 year of duration, but we'll be giving SAM at around dose of around 1,200 milligrams. 1,000 to 1,200 milligrams per day can be considered if you're going to use S-adenosyl-methionine. Mainly, our target, we need to elevate the methionine and decrease the methionine clearance, and not to avoid the oxidative stress and to prevent the hepatic stellate cell activation. So SAM can be given along with the management. Even for hepatic encephalopathy and other conditions, SAM can be recommended in the management, but the proven papers still need to be validated if you are planning to consider this.
Okay, thank you, sir. Sir, we have another question, which is regarding, sir, whether glutathione or vitamin E, which one has more beneficial effects on NASH? Considering the adverse effect of vitamin E, which antioxidant is safe for NASH in long term, sir? Sir, your thoughts on the same?
So, but the initial beneficial role for NASH in, vitamin E, as per P1s and multiple trials, there is a strong potential role for vitamin E has been taken over. But the one problem is, if you're going to use vitamin E at a dose of around 800 milligrams per day for a longer duration of time, there is high possibility for you to land up in either cancers and bladder cancer. Some case reports have been reported. So glutathione, along with that, a strong potential antioxidant, definitely can be considered in the management of non-alcoholic steatohepatitis. But as per the norms, the basic paper, the basic literature, as per the basic textbooks, what they've been quoted, the vitamin E is still having a strong potential role, but glutathione also taking a clear lead nowadays in the management of non-alcoholic steatohepatitis.
Okay, thank you, sir. Sir, the next question is regarding silymarin, sir, and how it acts. So what is the mechanism of silymarin, sir, in liver diseases?
So it's mainly, as you know, it has been the naturally occurring substance which is going to be derived from your milk cell. So what is going to happen? It will predispose. It will be involving in the reduction of free radical mediated damage. and also it is going to stabilize your plasma membrane, and it is going to be involving in stimulation of your new cell formation. New hepatogenesis is going to be there, and but the problem is silimarin. How long you're going to subject the patient for a longer duration of silimarin? And there are some proven papers to be used in alcoholic liver disease, and even for acute viral hepatitis. There are some papers are there to quote the beneficial effects, but excellent beneficial role in once a patient is going to land up with multiple other complications. Still more a questionable issue if you're going to use silimarin for a longer duration of time.
Okay, sir, we'll now next take the next question, sir, which is from Dr. Nabra. Role of antioxidant in yellow phosphorus poisoning, sir.
As we all know that the yellow phosphorus poisoning is a high possibility for the patients can go for acute liver failure and other things like what's going to happen in paracetamol and other toxicity, like what's going to happen in rat killer poisoning. But the yellow phosphorus poisoning is going to have a fatal, and the worsening of events in yellow phosphorus is not very high when compared to rat killer and other things. But yellow phosphorus, if your patient is going to have always a strong antioxidant like glutathione, definitely along with N-acetylcysteine can be added in the management of yellow phosphorus poisoning also, sir.
Okay, sir. So thank you. And sir, one more question we have received. Can astaxanthin be given long term, unlike vitamin E? Sir, your thoughts on the same, sir?
Astaxanthin, there are no much of contraindications, and we are now having much of papers, but definitely astaxanthin can be tried over a longer duration of time for a period of around 6 months to 1 year, and there are doses of around 4 milligrams to up to 20 milligrams. We can try out astaxanthin without much of contraindications and without much of complications can be tried, but we need more papers to validate these contents. But moreover, it's a naturally occurring event, a naturally occurring substance which is being happening, and how far our hepatology team is going to take over this astaxanthin in the management of acute liver injury. So we need more papers to document all these beneficial effects.
Okay, sir. So the next two questions, sir, again are on astaxanthin. So the first thing is, sir, what is the role of astaxanthin in lipid metabolism, sir, in fatty liver patients? Sir, probably.
I think I have discussed in my paper about lipid metabolism. See, what that's going to act mainly because it's going to prevent the oxidative stress, and also it's going to be involved in, there is high potential role if you're going to subject with non-alcoholic steatohepatitis, which means if the patient is going to land up with high liver enzymes in the background of, your abnormal lipid profile. So once a patient is having hypertriglyceridemia and the free fatty acid activation, accumulation, all this process is going to be there. To prevent that, astaxanthin is having a strong potential role, and also it's going to come down your lipid peroxidation, other process. So astaxanthin can be considered in the management, sir.
Okay. And sir, the next question is, what is the role of glutathione in any NAFLD patient, sir?
I think I've been quoted from a paper. Glutathione definitely can be considered non-alcoholic fatty liver disease because non-alcoholic is isolated fatty liver the patient can go for non-alcoholic steatohepatitis, one of the worsening condition based upon your hepatic fibrosis, other things, and then finally can land up in fibrotic, cirrhotic, and other hepatocellular carcinoma, other things can be there. So if you're going to manage with glutathione, the problem is if you need to subject the patient for a longer duration of time, at least around 300 milligrams of glutathione to be given over a period of 4 months or 4 to 6 months can be tried if you're planning to manage with glutathione over a longer duration of time.
Okay. So, sir, next one is a very interesting question. So, when to stop anti-TB drugs and when to start ATT treatment?
This is purely a drug-induced liver injury that's out of discussion right now, but even then I would like to talk. So once a patient is being initiated on TB medications, and we all should remember that based upon your RICOM, this Medusa scoring method, also based upon your ICE law. So these are the various laws being used if you're managing a patient with drug-induced liver injury in the background of drug-induced liver injury network. So in these conditions, if the patient is going to be initiated on anti-tuberculosis therapy, so what is the main thing you should remember that if the AST, if the ALT elevation, if it is going to be more than 5 times the abnormal limit, that is a strong role for this patient to stop this anti-tuberculosis regimen and to strongly consider this patient with alternative regimens. And once you establish the alternative regimens, once the liver function is going to improve and the ALT is going to be around 2 times of upper limit of normal, can be considered slowly to restart your drug at a dose. There are various guidelines based upon that. One is because of Chest Society, and one is because of British Thoracic guidelines. There are various guidelines for that. So if you're going to restart, always you need to start with the potential less hepatotoxic molecule and less hepatotoxic like either INH or rifampicin. And as per BTS, isoniazid can be considered, as per the Chest Society, what is being considered, rifampicin can be considered the initial molecule, followed by slowly we can step up. So if you're planning to step up the molecule, like first rifampicin followed by isoniazid at a lower dose to initiate to higher dose, followed by at last the most hepatotoxic molecule of pyrosinamide, if you want, can be add on to the armamentarium in the management of ATT induced liver injury.
Okay, sir.
Based upon
Thank you.
scoring and child scoring also.
Okay, sir. Sir, the next question is regarding how to confirm drug-induced liver injury.
That's what the discussion is about. Drug-induced liver injury is mainly based upon you should eliminate all the possible factors. Like if they see there in our medicine, in our clinical scenario, always you should remember if the patient is consuming alcohol, if the patient is going to present jaundice, doesn't mean that the patient is having alcohol-induced damage. Always you should remember you need to think for other factors, other perturbating etiology which is being predominantly involved. So even if the patient is chronic alcoholic, so we need to think for other factors like this. Always, this is a diagnosis of exclusion. So we need to exclude alcohol. We need to eliminate all the triggers. We need to rule out the infection. We need to rule out other possible triggers, other possible natural complementary alternative medication. All these things, as we rule out it to overcome. So once these things is being there, autoimmune markers, all those things, viral events, Wilson's. So all this basic workup, it comes to be negative, and followed by you're consuming some complementary alternative medicines. There is high possibility for you to go for a drug-induced liver injury, or else if the patient, even if the patient is going for ATT or chemotherapeutic regimen, there is high possibility for you to go for drug-induced liver injury. Once this drug-induced liver injury is going to be there, you need to rule out other coexisting infections. Definitely, it's the most important thing. Along with that, you need to consider antioxidants as other support, and that's what I've been discussing. AT elevation of more than 5 times of the upper limit of normal, along with some guidelines are being given, the various papers, the various grading systems, along with bilirubin also can be considered. So these are all the things can be added in the management of drug-induced liver injury.
Okay, sir, the next question is a very interesting one. So, sir, can these molecules like astaxanthin, glutathione be co-prescribed with UDCA? And, sir, when to know whether UDCA is not working?
So that's very difficult to answer most of the time, because we are not very sure. If you are going to see in gastroenterology, no perfect molecules have been proven, because it's only a symptomatic support. Once a patient is going to have a chronic liver pathology, always the patient has to go for transplant as the final line of management. So these are all coexisting supporting measures. So if you are going to subject the patient with UDCA or glutathione or other astaxanthin, other support, we are not very sure how far it is responding to that. So based upon, we need more papers to quote that, and along with that, so even if the patient be, so how far the fibrotic changes is going to improve, how far your liver parameters, your liver enzyme functions is going to come down, all these parameters has to be taken into account. As of now, there are not much of papers to document on these beneficial roles, sir.
Okay, sir, and we have one more question, sir. So in terms of, sir, paracetamol toxicity, can we use methionine, and how to use, or rather when to use?
So methionine definitely can be considered in the management of alcohol-induced hepatotoxicity, paracetamol-induced hepatotoxicity. But if you're going to use methionine, you should always remember that we need to start by, 2 to 5 milligrams of, 2 to 5 grams of oral methionine can be considered. Every 4 hours can be given, or a maximum dose up to 10 grams can be considered. So the first dose should be given within a period of 10 hours in paracetamol poisoning. So for paracetamol poisoning, the main line of treatment will be always N-acetylcysteine. That's a definite thing. But also you can add methionine along with glutamine support to replenish the stores. But as of now, in multiple centers in India, we are going only with NAC and other measures.
Okay, sir, and just one last question we have, sir, that is regarding NAC, sir. So your thoughts on the symptom, how to give N-acetylcysteine infusion?
It's really a good question, because most of the time, even in pediatric age group, we are not, there are various criteria are there, even for the adult patient who are present to us with evidence of even acute liver failure presentation, we can use NAC. Also in paracetamol toxicity, we can use NAC. There are various papers to go that. And if you are planning to use N-acetylcysteine, we can start at the rate of around 150 milligrams per kg over a period of 4 hours. So we need to take dextrose-containing solution, and followed by we can use 50 milligrams per kg over the next 4 hours. First 150 over the period of 1 hour, followed by 50 milligrams over a period of 4 hours, followed by 125 milligrams over the next 19 hours, and followed by we can give up to 150 milligrams per kg over a period of 24 hours. And total duration should be approximately minimum 72 hours has to be tackled. Has to be managed if you, and with the serial monitoring of other functions, if you're going to subject the patient with N-acetylcysteine, even for ALF, also for acetaminophen toxicity.
Okay, so sir, That's it from the question side. So I'll ask my colleague Jay. So Jay, do we have more questions on the portal?
So as of now, we have no more questions.
Okay, okay. Sir, yes, sir. So that is it about the question, sir. And sir, thank you so much for answering most of the queries, sir. Rather, you have taken a lot of questions. So, sir, can I now request Mr. MV Arun, sir, to
Yeah.
take over?
Good evening, everyone. Good evening, sir, and thanks, Shashank. So, thank you, Dr. Arun, for conducting such a lively session, sir, and particularly the role of antioxidants in management of liver injury, whether it is NASH or alcoholic liver disease, or even for that matter, drug-induced liver diseases. Sir. It was good to understand from you, sir, regarding the new antioxidants like astaxanthin as well as L-glutathione, which has been there for quite some time, and also compare and when to use which drug. That would have been, I think, a good takeaway for all our doctors. I also thank all our doctors and participants for attending this lively session. So thank you everyone for attending this program on a Sunday, which is of course busy day for each one of us for from our personal and family commitments. So thank you once again, Doctor. You are listening to Dr. N. Arun, who is the director of
Thanking you all,
Gastro
and
and
thanking you
Liver.
all for to be along with us even during this Valentine's event.
Yeah. Thank you, Doctor.
Thanking you
Any
all.
final words from you, and then we can close, Doctor. Yeah.
Thanking you all, and take care of all those things, and overcome this COVID in a successful way, and tackle the liver complications early. Refer the patients promptly to the gastroenterologist to overcome all these complications. And thanking you all for patient listening. So.
Thank you. You are listening to Dr. N. Arun, Director, Chandra Gastro and Liver Clinic, Chennai. Thank you, Doctor.
Thank you, sir. Thank you so much, sir.
Thank you, Shashank, and thank you, backend team, for the logistics support.
Thank you.
Thank you, sir. From here, I am ending the meeting now. Thank you.
Hello. Yeah. So, sir, the live stream has now ended.